what will be really quite a brief overview of the national model around neighbourhood health, because I think it's fair to say that it is still very much an emerging model. So if you joined us today hoping to get all of the answers around what that national model of neighbourhood health looked like, then it's definitely not me that you're going to get those answers from. But actually, in terms of the things that are emerging in the national model, we think that we've got a lot of things going on across Leeds already that feed really well into that, and also feed really well into the bits that the government are really wanting to focus on this year around developing in terms of neighbourhood health. So we're going to talk then a bit more about the Leeds priorities, and specifically around a piece of work that we've started doing with local care partnerships called proactive care. And some of that might be very familiar to some people on the call. For other people on the call, that might just sound like a whole load of health jargon. So hopefully by the end of today's session, you'll understand more about that. And then finally, in that way that when we normally do a what's happening in local care partnership session, we kind of look forward to the next quarter, we're going to finish by looking at what does this actually mean for local care partnerships, and what are some of the changes that you might start to see in the autumn as we shift towards this way of working. So diving straight in then to the National 10-Year Health Plan. And I think some people abbreviate this to the NHS plan or the 10-year NHS plan. It's really important that we do not see this badged as NHS, and particularly when we are talking about neighbourhood health. Absolutely, this is about some really key changes to the NHS, but it is also very much about recognising that health isn't just about health services, the things that keep us healthy and well, or the things that contribute to health inequalities and can make us unwell. We're all really well aware, and not necessarily limited to illness. It's also challenges like financial inclusion or any other type of inclusion or exclusion that people experience. It's things like housing, it's access to green spaces, it's that feeling of social connection, community, feeling like you're welcomed and you belong in the place that you live. So when we're talking about that 10-year health plan, and particularly when we're talking about what this means in neighbourhoods, it's really important to think this is not all about the NHS, and the NHS certainly doesn't have all of the answers here. It's about all of the things that we've been trying to do with local care partnerships in Leeds, which is bring that real breadth of partners together and try and give all partners equal voice, recognising that there's a whole range of different skills and experience that make up a partnership, and all of those are equally valid and have a really important contribution to make in terms of health. But then I'm now going into one of the bits from the health plan, which dives straight into things that maybe do feel quite health focused. So there's 3 key areas that have been pulled out from the plan that are key transformations that the government wants to see within the NHS. So the first of those is moving more things from hospital to community. And the way of flipping that and recognising it is that they talk about where you can and where it's appropriate, providing support to people in their own homes. That could be physical support, that could be people going in. It could also be using better use of digital technology as well, so that that technology also contributes to keeping people well in their home. If it's not appropriate to provide support in people's homes, then it's about looking at, well, what can people access on their doorstep in their own communities? What are the things that are right to deliver in that way, and really trying to focus down to the places that we live. And then it's recognising that some things might not need to be provided in a hospital, but actually they might need to cover a bigger area of the city, that you can't have it on your own doorstep in your own community because actually it's just not cost effective. There's not so much demand for those types of services. So there's an idea of developing neighbourhood hubs and that there are some services that might group together in a hub. And we can potentially get into hubs a little more in discussions and questions at the end of this. But again, the idea of a neighbourhood hub is still developing. It's not brilliantly well defined yet. And I think it can mean lots of different things. So if I was going to guess what those neighbourhood hubs would end up looking like, then I think what we would end up with is a model of the sorts of things we'd expect to see sharing a building or working across a group of buildings that are already in people's communities, already well used and effective. That would be one type of hub, but then you might have other hubs that are a bit more like some of the urgent treatment centres, some of the walk-in centres, some of the places that we've got more of the kind of diagnostic support from the NHS that we maybe wouldn't have in every community, but we would have some of them dotted about in Leeds. But all of that is still very much to be worked through. There is then this bit about analogue to digital. So this is twofold. The first bit of that is around making sure that staff who work within the health service have got access to digital technology that enables them to do their jobs better, that enables our systems to talk to each other so that we can provide better joined up care for patients, that as new tech is developed, we're really thinking about how can that benefit patient experience and person experience within health settings. And then there is the bit around tech for people themselves and how we can use tech to manage and support our own care better. And one of the key elements of that is development further of the NHS app. And for some people, that would be really great news that we do actually use our NHS apps to order medication, to keep on top of appointments, that we've got that on our phone in our pocket. But for other people that are maybe digitally excluded, that might be another thing where we feel like people are being left behind. So one of the things that we're wanting to consider as this develops in Leeds is what does this actually mean in terms of our digital inclusion agenda, and how do we continue to include people? And then we've got this really key bit around sickness to prevention, which is, I think, absolutely what we all want to see happen, but is such a tricky thing to do in a service that is under strain and tends to work in quite a reactive way. So people pop up, they need support, they need needs addressing there and then. And so we respond to that, and that's where our capacity goes. And what we've talked about for quite a while in Leeds now is making a left shift. So how do we move some of our support, some of our resource from reacting and supporting sickness to doing some of that prevention work earlier on, getting to people earlier in illness or before they get ill so that they are supported more effectively. And some of that is around who is the right person to do that from across our whole health and care partnership. So I'd said that there's lots of things that we've got going on in Leeds that already contribute to neighbourhood health. So there's a few of them just popping up across the screen now that we feel all of those kind of coming together helps to build what we see as the way that we are going to develop and deliver neighbourhood health in Leeds. I think that if we were a bit more sophisticated with some of our graphics for this slide, we'd maybe have a few missing pieces on that jigsaw. We'd recognise that we haven't got the full puzzle all properly put together just yet, that we need to do some work around that. But we recognise that we do really have some key ingredients. Quite early on nationally, when they were describing neighbourhood health, they came up with a model and an idea of 3 circles. And this is a kind of Leeds version of that model. So down the left-hand side of the screen, we've got the entire population of Leeds. And what we've tried to do is capture that with these circles that are described, some of those circles need to work for absolutely everybody in Leeds. And some of them are things that we need to get right for a much smaller group of people. So starting around that outside circle, which we're saying potentially needs to benefit all of our population, there are some key things that we need to have happen. So from a very health perspective, this is things like making sure that our community health services are provided in a standardised way, that we've got an offer that is our kind of core offer, that is the key that everybody can expect. That's not to say that there isn't then more targeted support needed for some people, that some services would be better delivered for some communities in a different way to others, but there's the kind of core that everybody should be able to access. Alongside that is a lot of work around modern general practice, which is responding to that need for people to be able to access their GPs when they can, to be able to shorten those times for people when they need to access general practice. And then using our data effectively in the way that we support and manage our whole population. But also in that outer circle is all of the non-health things that we talked about. So it is very much then around libraries, green spaces, good quality housing, people feeling safe in their community. It's looking at what are all the other things that we all need to live a good, healthy life and have good mental health and well-being. Once we then get into that mid-circle, we start to go down to a narrower group of our population. So this isn't things that we all need or that we all need right now. Some of us might not need it right now. We might need it at another time in our life. But this is starting to recognise where people have got conditions or they're starting to develop conditions, that we are starting to put in more targeted preventative support. So you could argue that things like a green space or access to good quality housing, they're preventative measures for everybody. They're the things that help to keep us all well. But then really targeting certain communities to make sure that where we know that people are not coming forward for cancer screening, or they're coming forward much later in that cancer journey, where somebody might be walking around with hypertension and not realise that they've got that high blood pressure, that they're at an increased risk of cardiovascular disease, that we really use our data and our knowledge and insight in our communities to think, who are the people we need a more targeted support for? And how do we work with the right partners, particularly third sector partners in this, to make sure that we have got that reach to those communities and we're able to get to people and work with them and identify and support their health needs earlier. And then finally, in this blue bubble at the top, we've got around 5% of our population, and we're going to talk about this a lot more in this presentation, because this is the place where the national model has really asked us to target first. And these are people who have already got quite a lot of complex health needs now. So they're already using a lot of healthcare services, but maybe we're not as joined up as we could be, that there might be duplication, that there could be poor experience, that people might be using a lot of services in an unplanned way. We want to try and get on the front foot with them and have them access services in a way that is planned and better supports their health. Okay, so I forgot that this slide has nice images that pop up as I go along. So I've talked through the whole slide for you with the creating the conditions, etc. So I'm just going to move us on now, and Catherine is going to talk us through the next piece.
Thank you, Kim. Hello, everybody. I'm Catherine Sunter. I'm a Programme Director at the ICB in Leeds, focusing on neighbourhood proactive care and Home First too, and working really closely with Kim and team on this and how we support the development of proactive care in neighbourhoods, as Kim said, in its broadest sense. You may have heard of the term Home First. There was an original Home First programme that very much focused on how to support people in leaving hospital in a timely way, and that has been expanded now to Home First 2. Home First 2 is one of the 4 priorities of the city. So all health and care organisations in Leeds have signed up to 4 priorities. So these are 4 things that every health and care organisation Leeds have kind of signed up to and said that we'll work on in partnership, as we know that there's the kind of greatest return on this when we work together, has the greatest impact. The others are community mental health transformation, CVD and hypertension, and children with special needs, and the 4th one is Home First Phase 2, which I'm just going to talk a little bit about now. So the vision is that in partnership with local people, neighbourhood health and care services will work together to proactively prevent health and wellbeing deterioration, ensuring more people can live independently and be supported in their own homes. And that's why this Home First programme has been expanded. So as I said, Home First one really focused on how do we support people in leaving hospital in a timely way, which is of course really, really important, and neighbourhoods have a really important role to play in that. However, actually, we know that that it's much better if we could try and prevent those people from going into hospital in the first place through working with people more proactively, really understanding their needs. And so this is what this programme we're going to talk to you today is about. It's got 3 parts. The first is about about implementing a neighbourhood proactive care model that works with people and families to improve health outcomes for those most at risk, as Kim talked about. And I think it's really important we reiterate that message that neighbourhood proactive care model is not an NHS model. It is a genuine partnership model with all the important roles that people from both NHS and non-NHS services have in keeping people well. We will continue that focus on building on Home First and continuing to develop our intermediate care offer, because we know that no matter how much focus we put into prevention and supporting people in that kind of proactive way, there'll still be times when people need to go into hospital, and we need to support them wherever possible in either not going into hospital or being able to leave in a timely way when they do. And we're also undertaking a prevention diagnostic. So what we're going to talk to you a bit about today is the population that we're looking to proactively support. And I think some of you in your mind will be saying, actually, how do we know that this is the right population? Do we start with a population that has a significant need now, or do we need to proactively focus on those people who aren't actually popping up now in health and care services over time, but could be in 2 or 3 years' time? And that's particularly what that piece of work looks to do. But I'm going to talk to you a little bit more about, number one, that implementing a neighbourhood proactive care model. So if it's possible to move to the next slide. So these are the types of people that we'll be looking to support through that proactive neighbourhood care model. And I think what you'll notice, hopefully, as you kind of scan through some of the stories on here, is that these people are seen as being at risk of going in and out of services, using lots of kind of unplanned care services, not just because of their health conditions, but the other wider determinants, the other things that they've got going on in their lives. So the first example talks about somebody who has multiple long-term conditions, and had to give up work as a result of that, and the challenges in going for multiple appointments because of finances, etc. So these stories really, I think, set out that importance of that multi-agency approach, the really important role that local care partnerships have in these proactive care models, because it's not just those health challenges that really lead to people going to using services in an unplanned way. It's really those wider determinants of health as well. And I think these stories kind of really set that out. I think what's really important as well, it demonstrates the importance of proactive care in understanding the whole person, in understanding what's important to them and what's going on in their lives. And I think because of that, it's really important we say not only is it the population that you're proactively managing, but also their carer as well. So I think carers have a really important role in this programme. I think this really kind of rang true to me when we did a piece of work on respiratory, and last year we did a deep dive into a number of cases, 9 cases of people who'd gone into hospital for respiratory disease, and as a partnership we looked at those cases to understand, could we have done something different. And I think what was really interesting is for about 7 of those cases, the day they went to hospital, they'd seen 3 or 4 agencies the day before in an attempt for something to happen that meant they didn't have to go into hospital. And in one of those groups was a clinician who said, I was one of those people who saw that person and I went in and out and I had 10 minutes and I treated the condition that was in front of me. But what I didn't recognize was all this was around the carer strain, was around all the other challenges in that person's life. And because of that, I had to treat what was in front of me. But if I'd have known all this, then I wouldn't have taken that course of action. And I think that's what proactive care is really about, is taking time to understand the person, to understand what's needed to kind of keep people well, and to be able to anticipate their needs and pick up on things like carer strain, pick up on things like anxiety, and all those things that we know culminate eventually in perhaps somebody having multiple unplanned care attendances that perhaps could have been averted if we'd have known about some of those challenges and been able to address them proactively earlier. So I think these stories really kind of demonstrate that and demonstrate the importance of that kind of local care partnership role in this project. If it's possible to move on to the next slide. So who are we looking at? Well, as Kim said, when the government talk about this neighbourhood care model, they talk about 5% of this, 5 to 7% of a population, and we think we've got a really good idea in Leeds of who's in that population. So we are looking at a population of around 47,000 people in total, and that population that we think is amenable to change for proactive care, where we think we can make a difference. So in the left-hand circle, you'll see 10,000 people of that 47 are made up of people with multiple long-term conditions, which we know has an impact on the amount of time that people have access to health and care services. The circle on the right is that people live with moderate to severe frailty, and we know that that as we get older, we know that we have more health and care and broader challenges that lead to people needing to use health and care services more often. The really interesting part of that population, so it's possible just to go back a slide, is the bit in the middle, which is the 17,000 people that are that have both. And so our hypothesis is that through offering proactive support to this population, they'll experience better outcomes and better value for the system. Now, we know that we can't in Leeds suddenly start proactively managing 47,000 people. That would be impossible. But what we've agreed is that each PCN and LCP working together proactively manages 2 to 3% of their of this population in year 1, and the system has an ambition of moving up to 25% in over the next 5 years. And you'll just see on the right some of the key stats around that population, such as a quarter living in IMD1, 7% living with dementia, 12% having a carer, which just gives you a bit of a sense of that population. So our job now is to work in each of our neighbourhoods with people such as yourselves to establish what would be the right population. How do we pick those people in each neighbourhood where proactive care would have the most impact? If it's possible just to move to the next slide. And you'll see in the, sorry, I don't know if you can hear the ice cream van in the background out of the window. It's just distracting me for a moment. So it's quite a broad population, looking at people with long-term conditions and then people with long-term conditions live with frailty. But I think this diagram demonstrates why it's so important to get this right. So we know aging is a factor in getting frail, and we can't do much about getting older, but we know that actually the way that somebody's supported once they have one long-term condition has a real impact on how quickly they look to they then get multiple long-term conditions, which then really has an impact on the speed at which they become frail and severely frail. And as you can see on the slide, there's a statistic around by 2025 will be 2035 will be twice as many people in Leeds living with frailty and multiple long-term conditions compared with 2015. So the importance of really doing what we can to proactively manage people, to try and prevent people becoming frail, moderately frail, severely frail as far as possible. And we know this is a particular challenge in our most deprived areas, as it says at the bottom of the slide. People in our most deprived parts of the city develop multiple long-term conditions around 10 to 15 years earlier and spend longer time living in frailty. So I think this really kind of does sing to that kind of health inequalities focus also. It's possible to move to the next slide. And we can see here actually that when we look at that 5% of a population, those 47,000 people, actually, that population use a disproportionate amount of health and care services. So they account for 80% of social care packages in the city, 50% of non-elective bed days, much more primary care appointments than other people. Than other people outside of that population. And really the question is, in terms of proactive care, through working together, through working in a much more integrated way, through focusing on how do we keep these people well, rather than seeing them when we're sick, one of our aspirations is that we can start to reduce some of that and start to shift some of this more kind of this more reactive activity to proactive activity through really just understanding people and how we address their needs much more and looking at them in a much more proactive way. And I think it's probably worth pointing out, we're looking at those stats now and we see that that's disproportionate, but actually if we were to take that population and just take the people in IMD1, we know that would be even starker. And if we were to take, say, the top 5% of people within that population and look at their health and care utilisation, it would be even starker. So this is really, really important for people, for their families, and also for the system that we start to work in this much more kind of joined up, holistic way. If it's possible to move to the next slide. I think I'm handing over to Kim now.
So while we're waiting for Rachel to bring up the slides, people might be feeling like getting really deep dive into proactive care feels like it's quite a long way off from where we started, which is neighbourhood health, that we've kind of gone down this rabbit hole of data. Brilliant, thanks Rachel. I've got those back up now. But actually, when we're talking about neighbourhood health benefiting those people that Catherine's just talked through, that kind of 5%, if you take your mind back to the case studies that Catherine shared right at the beginning, it really very much is around making sure that we're having a positive impact for them, not just in terms of their health, but picking up that kind of breadth of things that are contributing to it. So yes, we need to manage ill health well, but we also need to make sure that they're supported in a number of different ways. That target group that we're looking at in terms of the proactive care initiative, there are 3 key areas that we're looking at. And for some of our local care partnerships over the summer, we've been coming out to you with data packs that have said for your population in your local care partnership, these are the people that we're looking at. So when we've got this logic model, we've tried to capture the initiative right at the start of kind of breaking down for most people with proactive care, the people that benefit most from it are those people who are living with frailty or those people that are living with multiple long-term conditions. And we've got a list of about 9 long-term conditions that we look at, and we say people have got 3 or more of these long-term conditions, then those are the people that we want to start to really take that proactive approach with. So we want to understand what's going on with them. We want to look at how we can join up care better, but we also want to look at what are the other things that are going on in their life that might be contributing to ill health. And for some people, they're both frail and they've got multiple long-term conditions. So in terms of what that might look like for people, we get that data, we bring it out to you as a local care partnership, and we share your data with you. We do a kind of initial thing to say, these are your populations. Is there a particular one that you feel as a group of partners you would want to focus down on and understand a bit more of? And then we can break that down much further. So in some of the things that we've done, we've kind of generated heat maps, and we've said, these are literally the streets or the neighbourhoods in your area that people are living that are most impacted by this. And for something like advanced respiratory, that could really open up conversations where people are saying, well, actually, what's air pollution like in that area? What's the housing stock like? What are the other things that could be contributing to their condition, that if we did something different, that might actually also support that person, that it's not all health input. So we use that data and we combine it very much with insight that we get from the local communities and from the local partnership to then build up and look at how do we work together to support those people. And then in terms of how we support people, it's very much around the proactive care teams that primary care have already got established, working together with all of those other partners. So what Rachel will go into a little bit more later is some of those kind of next steps in terms of wrapping partners around this cohort of people. But when I hand over to Catherine, what we're looking to do is then think, well, how will we know if we've had an impact and if we've made a difference? And so what we're trying to do is work through, we've got short, medium and long-term outcomes here. So by short term, we mean what are the things that we might expect to see in the next 3 months if we're starting to work differently with people. For medium term, we're then looking at, and then sort of 3 to 6 months-ish, what are the things that might start to impact positively on people? So you'll notice that the short-term outcomes, a lot of those, their outputs are things that we might start to see. But once we get to the medium term, we're starting to think about, what does this really look like for people? Are they starting to see a real difference in this? And then the longer term outcomes, which is kind of 6 months onwards, is then starting to see, and is this having an impact on the population as a whole, and what does that look like? So I'm going to hand back over to Catherine now, if you can move us on, Rachel.
Thank you. Thanks, Kim. I think, yeah, as Kim says, we know instinctively, and you'll all know in your interactions with people, that this makes sense, that this is a way of working that must have an impact. And I think, and the stories on this slide, and these stories have come from some of the respiratory work that's been happening in Seacroft and Crossgates, and just to kind of pick up on what Kim said there, you know, and I had a colleague who attended the MDT there the other day, and they said they were expecting quite a lot of quite technical respiratory type conversation around that MDT table, and actually it was all around the wider determinants of health, and you know, people being supported to address some of their financial issues, and that was one of that was one of the reasons for one person why we felt they were going in and out of hospital for respiratory disease, or one of the root causes. And so we know it works, we know it makes sense, but we need to be able to demonstrate that as well. And these are 2 examples of that. We've got John, a 71-year-old male living in Seacroft in social housing in a house with steep stairs, who was saying there is the house isn't necessarily set up for their needs. And their diagnosis has been in the last 12 months of life, and I've been in and out of hospital for respiratory and other reasons. And we've got Maggie, a 55-year-old female married to John, and have a daughter who all live together. And Maggie's trying her best to support John and to keep John out of hospital, but finding some things that are getting in the way. And this demonstrates some of the things that care coordinator in this case, but through pulling in other partners through the relationships that they've got, have done to support working with John and Maggie, understanding what's important to them, and the things that they've done to help to support them and help to ultimately keep them well, and keep them out of hospital, looking at what we can do to proactively support people. And you can see there's some clinical support there, but there's also, you know, a lot of non-clinical support around gas and electricity debt, getting a blue badge in place, and all these things are just so important, as well as planning ahead. And so So lots of outcomes achieved, both from health related outcomes around John hasn't been in and out of hospital since they've been receiving this support, but also those broader outcomes that are really important for people, such as Maggie being supported as a carer and being able to reduce a day at work to care for John. So these stories we know are compelling, but we also know when we're all working in a system with really constrained finances and resources, we need to know that ultimately this adds up. This adds up into something that will make a difference for us as a system when it's undertaken at scale. It's possible just to move to the next slide. And that's what we're really trying to get across here. So I've kind of spent quite a bit of time in my career working in cost reduction in hospitals, and that's kind of, it's not easy, but we have those kind of set measures that kind of change quite quickly. So we can look at length of stay, and we can see length of stay instantly kind of reduce as we put initiatives in place. We can look at an outpatient's due to follow-up ratio, something like that, and we can see how that changes. And I think one of the challenges for us doing this as a system, despite the fact that we know that it works, is that you can't necessarily instantly see that change. And so that's why, as Kim said, we're really keen to understand what are the short-term, medium and long-term things that we'll see change that ultimately mean things are getting better for people, for their families, for staff, and ultimately that brings benefit to the system. And so one of the first things that we'll be looking at is the number of people that are actually being proactively managed. So we'll be looking to understand if we're going to get up to that kind of target of 2 to 3%, because we know that unless we do that, and unless we're supporting you as PCNs or local care partnerships to do that, then no change will be made. So this is one of the things we should instantly see, an increase in the number of people being proactively managed. If it's possible to move to the next slide. But of equal importance is that staff and teams that you work in, and that kind of neighbourhood proactive team feels they've got the right people around the table and the right relationships to do that. But how do we know? So I think many of you will have undertaken a survey to provide a baseline on proactive care and network teams, where we are now. And we know because we're at the beginning of a journey, but there's some work to do to get to where we need to be. But we're going to be refreshing that survey just to understand if through some of the support that will be provided to LCPs and PCNs to do this, and through kind of, I suppose, almost just learning through managing that initial population, and through us understanding the themes that are coming out of that survey and looking to address them if things change. So that will be another measure for us. Do you, as people around the LCP table, feel you're getting better equipped to undertake this type of role? Is it possible to move to the next one? So also of importance, we've talked about how this really is not just health, but the wider determinants of health. What we'll be interested in understanding is, what are the interactions that are happening that wouldn't have happened otherwise, that wouldn't have happened had that person not been proactively managed. And I think that's really important for lots of people who are involved in LCPs, because we know that through doing this, for example, certain third sector organisations could get more referrals, etc. And we need to be able to demonstrate that, and then the knock-on impact that's happening. And so what we'll be looking to do is to make that visible, and to work with within the PCNs to understand where the referrals are happening that wouldn't have happened had we not been proactively managing that population, and had we not had such that kind of diverse range of partners around the table within the network team. So this is another way that we'll be looking to demonstrate impact and change. It's possible through to the next one. And then it's really important that we understand quality of life as well, because we could provide proactive care and in all sorts of ways, but actually it's got to be a really good experience for a person, hasn't it, if it's going to work. And therefore there's a standard survey called the EQ5D, which we're going to be providing some tools to support local network teams in understanding. So people being proactively managed will be asked to answer a few kind of simple questions at various points in their process of being proactively managed to understand if actually doing this improves people's quality of life, because we know that when people's quality of life improves, they're less likely to have to use hospital services in an unplanned way, etc. So this is a really kind of important metric about people's experience. And we'll also be having a similar survey for carers as well. So really, really important. More people are going to be proactively managed. We're going to see local neighbourhood teams feeling increasingly like they've got the right relationships and the right support to do this. And then a more medium-term impact should be as people start to be proactively managed, as carers are part of that, they start to feel a better quality of life. If it's possible to move on to the next piece. And then, of course, there's the question of ultimately, does that change people's health and care utilisation and how they interact with services? And in Leeds, we've got the Leeds data model, which is our linked data set that allows us to have a really person-centred view of their care. So if we understand the people who are being proactively managed, then we can look at the data collectively as a whole and understand where the different shifts are in their care. And this isn't just about hospital activity, this is about GP activity, community activity, social care activity, etc. How does that change when somebody starts to be proactively managed? And we'll be looking at that on in a kind of a larger, big picture, but we'll also be able to pull out some theographs. So a theograph is a kind of a pictorial view of somebody's journey through health and care, and you should be able to see, as it shows on the right of the slide, if there's changes for individuals before being proactively managed and after being proactively managed. So we'll really be looking to understand what the change is, but not only just what the larger changes, but actually are there any particular characteristics of people who proactive care, who we manage proactively, it has a greater impact on them than others. And that learning will support us collectively moving forward in thinking about, okay, who's our next population? Who are the next people we're going to proactively manage? Who do we know this has a real kind of significant impact on? It's possible to move to the next slide. And we know that we ultimately need to think about what will be the broader impact for the system, and our estimate is that through proactively supporting this population, between 11 to 18 million pounds in reoccurring financial / resource benefit by 2031. So a lot of it's not necessarily going to be financial benefit, but a shift in resource to doing things smarter, getting more value from what we do. And that is predicated on a similar model to what we're adopting in Leeds, in Birmingham. And you can see at the bottom of the slide what the impact was in Birmingham once their integrated neighbourhood teams were put in place, and we're looking to kind of create some links to them to understand a bit more about what they did, and it's also based on us moving from 2 to 3% of the population in 25-26 up to 25% of the population in 2031. The side of the slide demonstrates how those figures have been established through fewer unplanned bed days, fewer A&E attendances, GP appointments, outpatient appointments. But I think we don't have social care in here. We don't have community activity in here. So in reality, this impact could be even greater. But I think what's important, and through what you've just seen in how we're going to look to understand impact, is that we're going to be adapting this year on year as we look to really analyse what the impact has been on what we've done, where we've had a big impact, where we've not had as big an impact as what we thought, and we look to adapt and change what we do. So this is likely to change over time. if it's possible, just to move to the next slide. And I think really this shows that that we're already making a difference. So we know that a number of PCNs, LCPs are involved with active respiratory and proactive planning work. That's already into implementation. A number are involved in frailties, injuries and falls work with falls hubs, etc. And that's getting close to implementation now. So a number have been involved in 3+ long-term conditions, including mental health and frailty proactive care. But the aim is that every area will be undertaking an element of proactive management by the end of this financial year. I think I'm passing across to Rachel.
Thank you, Catherine. Hi, everybody. I'm Rachel. I'm the Senior Development Manager here within the Local Care Partnership Development Team. So what does this all mean for LCPs, local care partnerships? What does this mean for all of our fantastic partners working in neighbourhoods? What does it mean for our vibrant and wonderful communities? Just reflecting, really, it's so great, isn't it, that we have the foundations of our LCPs to build on. We've been talking to colleagues in different parts of the country and everyone's in a slightly different place, so it's a great time to be in Leeds. In terms of some of the work that is happening at the moment, some LCPs, as Catherine mentioned, have already been working with the Healthy Leeds Plan priorities around some of the topics that are documented. So after a really detailed diagnostic phase of understanding some of the issues, for some of the priorities, we're really moving to practical work happening on the ground. We now have established network teams and multidisciplinary working. We have better relationships and trust between teams, which is fantastic to see. Partners are commenting to me now, actually, I really do see the value in what each partner brings now more than ever. We really do feel like Team Seacroft or Team Crossgates, for example, it doesn't matter who it is that employs us, we're all working together as one team on behalf of our local population. And interesting, once again, really reflecting on the social wider determinants of health. That's why we need all partners engaged in this, including third sector colleagues. So it's all about holistic care and support, and really good to see a number of third sector colleagues on the call today. But ultimately, people and their families are starting to feed back that it's making a difference, which is all that matters. So we're busy working our way through the other LCPs, so socialising what the proactive care programme is all about, having a look at some of the data for your LCP, plus understanding what it is that's really important to partners. So really twinning and putting insight and local knowledge alongside the data so we can understand these people and the characteristics and where we can do some change work. But it's really led to some great discussions around being really curious about which population to focus on. Which areas, what are the streets that they live in? What does their pattern of interacting with health and care services look like? And this is leading to LCPs really agreeing which group of people they would like to work with first. So agreeing that together as a collective group of all partners, so not one partner on their own deciding. And really sort of looking at this as a new way of working rather than a time-limited project. So the start of, very much a new way of working that will continue. And we've got some helpful tools to support LCP partners in agreeing where it is that they'd like to focus. This is an example of one of the data tools. This one showcases what the overall Leeds proactive cohort looks like. But in these sessions, we look at an example from your LCP. And the data team from the ICB are excellent, and they really highlight areas that partners might like to understand more about, where their interest and patterns, for example. So it might be in your area, you might be looking at moderate to severe frailty cohort. Perhaps you might see there's a high number of people living with dementia. Should we look at that? But it also might be that's a high number of people smoking or maybe using alcohol in the population of people with multiple long-term conditions. Could that be a place to start? But really, it's always about twinning that and connecting that back and validating it is what you see in practice, or people that work in the local area, and also validating that with local people. And probably can't emphasize enough, this is about people, and the data is just a starting point. So it's real people in our neighbourhoods, people that you will recognise, people that you're working closely with. This diagram, it's really sort of thinking about what a networked MDT or network team looks like in terms of neighbourhood health and proactive care. So we really want to be thinking about who from the whole breadth of partners within a locality, within an LCP, should be involved. So of course, our fantastic clinicians, but also acknowledging the wider determinants of health, things such as housing, such as money worries or employment. So we really need those partners who are real experts in navigating that side of things. We really need them included as equals too. So that true holistic approach to care and support. And it's not all of the partners who are needed all at once. It's considering who is the right person to respond at the right time and at the right level. So how do we use care coordinators and similar roles to pull the right people in when they're needed? And to do that effectively, we need really strong relationships between those partners in the locality. So people to have name contacts that they know they can ring up and chat through issues with. They can talk through patients and clients. And actually, it's all about working proactively, managing this population. And important to say, although we will have our MDT meetings, it's not just about the meeting, it's about the day-to-day work that happens. It's about the culture. I'm really pleased to share there's going to be some OD, some organisational development support that will support this direction of travel. This neighbourhood health work also gives us another opportunity to really test out and challenge ourselves. Are we doing enough with local citizens and communities? So how are we at a neighbourhood level working with communities so their voices are at the heart of neighbourhood health and throughout? So that could range from collecting community insight to co-designing interventions in a genuine way, but around also co-delivering with partners. How are we really giving people power and agency to shape what it is happening in their community? There's some great practice that's already happening here in Leeds that you guys will know about, and so many local assets to build on. So particularly as we know about the impact of the wider determinants and what it is that people report as keeping them well and flourishing. So those local places, local organisations and groups that all contribute to that. As Kim mentioned, it's about delivering care closer to home, going to where people are, to trusted places. Starting to see some really good innovation work. So starting to see health checks now being delivered in community settings. So looking at third sector buildings, looking at places of worship, local supermarkets and businesses. But really it's about asking people where and how they would like their care delivered. So there's lots of early learning that we can take from this and share across LCPs. I wanted to shine a light on one of the initiatives around sort of working and genuine working with communities. So this is such an exciting development in Seacroft, brokered by the We Are Seacroft Alliance, so the local community anchor network, and via LS14 Trust. We're in the process of establishing what we're calling a community health panel, so a think tank for community-led research and consultation. And that's a core part of the Seacroft and surrounding areas LCP. But this is around local residents working with the LCP to undertake engagement and community-led research and then to co-create solutions. So we've got 10 residents to start with, all really well-connected people. So each of these residents has a network of 50 to 100 other local people. They have experience of navigating the system themselves as patients, but also they're passionate about making a difference. So we know these local people are so well connected. They're really going to be representing the views of their friends and neighbours in this work. And this builds on 5 years plus of the LCP working with the local community in this area. So there's very much a maturity of trust and shared values already in place. But ultimately, we want to really ensure that the health and care strategies are informed by community, that we're continuing to build that trust and fostering that equity. So these people are working with us already on some of the priorities, the Healthy Leeds Plan priorities, but these local people will also be key to informing priorities going forward as well. So some of the outputs that we're really hoping to gain from this, really around increased community capacity through skill building and leadership. But looking actually, can we learn from this one? And could this be a scalable model for integrating local voices into healthcare planning? So we're trying out paying people for their time, acknowledging their expertise, really putting people as an equal partner in LCPs and neighbourhood health. And would like to move to have local citizen reps from the panel as part of the LCP leadership group. So in a way that works for them. But again, this is test and learn work, so really keen to share some of the findings, but also know that in other LCPs, they'll be doing other great things, but really sort of looking at where have we got citizen engagement models wrapped around neighbourhood health. Where do we need to do a little bit more work on that? And mentioned before, really, we want to move to this is just the way that we do things around here. This is business as usual. It's moving away from this being a special project or a time limited thing. It's a culture change. We're going to be having leadership teams in each of the local care partnerships. So please don't worry if you haven't got one. We want to work with you to get one set up, and there's absolutely tons of learning from the ones that have already got a leadership group. And the starting point for those who don't have one will very much be those leaders who need to be engaged in helping operationalise proactive care. But again, really sort of challenging the leadership group so they all have really strong values, that they all value each other as equals. We're going to be setting up an LCP leadership forum to enable sharing of what's happening across leadership teams. So we create a space, hold the space for that really valuable peer support and that rich learning from each other. But it's also a way of sharing back to the system, how is this neighbourhood health feeling on the ground? Are there any common niggles or barriers? What does it really take to help this work flourish? And then looking at some more enhanced communication so everybody feels able to engage in this work in a way that feels right for them. And then let's not forget some of the enablers that will help this work. So additional support for the infrastructure, so things like estates. So how can we have people co-located as we start looking at some of the exciting health hubs, looking at IT, looking at shared care systems and records, looking at organisational development, how are sort of experts in that line of work helping us to create the conditions for this work to really flourish. And I really would say these are the things that will help us sort of hardwire how we sustain and scale change in Leeds. But yeah, in summary, it's like such an exciting time to be in Leeds. Thank you. Stop sharing now.
Okay, everybody, thanks so much for sticking with us and listening to what is quite a lengthy presentation. I've been having a look at some of your questions in the chat. We'll try and get through as many of those questions as possible. And if by some chance we actually get through everything before the end of the session, we can open it up to any more questions. What I will say at the start of this, in terms of answering your questions, is two things. One is we are coming at this very much from the perspective of local care partnerships, and some of your questions or comments are much bigger than local care partnerships. So we're not actually in a position to be able to maybe give answers for those. We can probably just acknowledge that that absolutely is a challenge or a problem, but we'll do our best to cover that. And then the other bit with this is that some of the questions that you've put in there are equally some of the questions that I have got. So for some of those questions that you're asking, it is probably a case of actually, it's really great to have those questions. We can feed any questions and any challenges into what we as a Leeds system are looking to develop as neighbourhoods and try and influence and shape that. But certainly we will not have the answers to those questions now. But what I'm going to do is start to work through some of the questions that did pop up in the chat. Some of them have probably got quite similar answers to each other. So where I think that they kind of group together, I'm going to pull them out and group them in that way. And I might pull in Catherine or Rachel to pick up on certain ones. So there were a couple that came up around enablers, and Rachel touched on enablers just towards the end there. So there was one in the chat that was, how do we ensure that health information is shared appropriately with key agencies that support people, i.e. home care services or voluntary sector, as they do not have access to shared care records? And then there was another one a bit further down in the chat that was, and I think it's higher up actually, I think it was one of the first ones that said neighbourhood hubs are an excellent template to deliver a person-centred care, providing convenient access to integrated health and wellbeing services, promoting prevention, early intervention and addressing health inequalities. But will there be a budget to cover hub costs, i.e. hire of rooms, access to transport and the wider services, especially for third sector providers. Two really big questions there, and two that are a massive impact for our third sector as well. Within Leeds, as touched on by Rachel, we've had a number of enabling groups that have been in the system for a little while that have been trying to dig under some of the thorny issues that we need to get right as a health and care partnership. So that's workforce, digital, and estates. And as we're moving more towards this neighbourhood model, these three enablers have got those kind of neighbourhood ways of working in their site. So it doesn't mean that we're necessarily any closer to getting any really clear answers on these things, but they are recognised as challenges and issues. So we do know that we need to get to a place, and we've had the Leeds Care Record for a while. There's a care record that we'll be joining into eventually, which is being developed at a West Yorkshire level that will enable better sharing across borders, which if you're in one of our outer area local care partnerships, you know is another challenge if people go to one of the hospitals that are just across border, and how we get that kind of join up around care. So there is that push around how do we make sure that we've got integrated records that talk to each other, and then how do we make sure that the people that need that information sharing have actually got access to the information when they need it, and that includes people like home care providers and third sector. The fact that we've been working on this for quite a while now shows that there isn't a quick and easy solution to any of this, even for those people that work in statutory organisations, without then looking at some of our partners as part of it. So I'm not promising that this is going to be a quick fix because neighbourhoods is suddenly a real focus, but it is something that we are continuing to chip away at and work at. The other bit that I would say with that is that diagram that we had up that described the networked team. It is about how we also have those strong relationships, connections, have a network team that actually can work effectively together, so that whilst we are waiting on digital and technologies talking to each other to make things easier, it isn't our only route to be sharing things with each other, that we are also actually feeling like we're genuinely working as a team. And those two do kind of fit together. So it's not easy in terms of, well, actually the digital record is consistently the thing that people tell us would make the biggest difference to how we work together. But it's around not just relying on a digital solution coming. And then similarly, in terms of estates, we have got an estates board that looks collectively across our shared estate that is now also thinking, well, in terms of neighbourhood hubs, what does that actually mean? There is a third sector representative that sits as part of that estates board. It isn't just looking at statutory estates, it's looking globally across all of our estates for solutions. In answer to a number of the questions that have popped up in the chat, there is no new money to do this neighbourhood work. We're in a system that is under a lot of strain, both in terms of demographic growth and cost pressures. So it's not like there's a pot of money come with neighbourhoods that suddenly unlock that makes either capital investment or some of that revenue stuff easier, or makes it easy to flow from one organisation to another. So we have still got all of the challenges today that we were operating on previously, but there is potentially some capital that's going to be made available around the neighbourhood hub work. We just don't know how much, which buildings, which areas across the country would be prioritised for those. We are obviously keeping an eye on that and any other opportunities around that kind of capital that might help with things. In terms of, I can't remember if it was you, Don, that put the question in the chat, but particularly around third sector buildings and use and that kind of financial bit. Alongside those enabling boards that I just spoke about, we also now have a financial board that is looking again at that kind of, and what do the financial flows look like that make some of these things a reality. So it's recognising that we don't just need that kind of the digital, the estates, the workforce stuff as enablers. We also need to look at finance as equally a barrier or an enabler to making these things happen. Again, we don't have any answers on that. It's not like a group of finance directors have got in a room and the problems are solved. This is a really tricky thing to work through, but we at least have recognised that that is as important as an enabler as the boards that we already had established and set up. So, Rachel, I'm wondering whether I can pass to you the question about are all LCPs as proactive as Seacroft in working with the third sector, and talk a little bit about that kind of engagement piece a lot more.
Yeah, sure. I mean, I guess we'd all reflect each LCP has its own personality and its own their own areas of strength. I think what I would say is we're very much so working with LCPs to create the conditions for partnerships to flourish, which would very much include encouraging engagement with third sector. I think you don't have LCPs without third sector. I think part of our role would be to share where there's some like unique, really good practice and share that across different LCPs and what the learning is, but also not being prescriptive in terms of each LCP having to do the same thing. So it'll be up to LCP partners within that area to agree and decide how is it that they would like to do their community engagement, involve that local community. And probably we can do some more work and bringing all local care partnerships together in terms of learning from each other and sort of going even sort of further faster. Yeah, I would just say third sectors need to be such a key part of LCPs, and we would sort of challenge where we didn't see that was happening. Yeah, and encourage that, yeah, more forward thinking way of working. But I think it's good to acknowledge it really at this stage.
Thanks, Rachel, and thanks, Dean. I've just spotted in the chat you've put in a comment about your involvement in Hatch Local Care Partnership with third sector, and I think just echoing what Rachel says, we've got some absolutely brilliant third sector organisations across the piece that help to connect local care partnerships into their communities. There's very different ways of doing it within the different local care partnerships and different places. I think what we're really keen to get better at is sharing that good practice across from one local care partnership to another. It's not about necessarily one picking up and lifting what's going on in another area, but it's about making sure that you feel connected to what's happening in other parts of the city and that you can think, does that work for us? Or actually, do we want to shout about some really great stuff that we've got going on that others might benefit from? So we just need to look at how we really use our learning forum type approach for a little bit more of that. I'm just going to pick up, there was a couple of questions that were around how we involve the independent sector. So I think that in terms of independent sector, we've done bits of work with independent sector. And again, this is us kind of, I guess, responding very much from a local care partnership perspective rather than how we work across Leeds with the independent sector or how we work as the neighbourhood model emerges. So first up, Michelle, I would definitely say I'd really welcome us getting some time in and exploring how best we can work together around this. I think the networked team approach is one area where if it's not explicit that that includes independent sector, it absolutely does. That network team is about anybody that is directly involved in someone's care. And we all know that for some people living in the community, it's actually those home care workers that are in and out of people's homes multiple times a day that are the best positioned to notice where something is not right, but maybe feel the least connected with the rest of the support that is going in that neighbourhood. We have started to unpick that a little. So in some areas, we've had home care agencies have come along and been part of the sessions that we've been running over the summer that's been looking at the data for different. Oh, sorry, I went on mute there. Yeah, for some, it's been looking at the data as part of their local care partnership and thinking about what do we see, how does this resonate with the people that we support. We've been looking at, in terms of the work that we've been doing with Frailty and Falls in Armley, really getting the home care agencies involved in some of the conversations early doors on how we shape that initiative and where they feel that they can really support and add value and work effectively with partners. But it isn't one that we've fully thought through in terms of what does this actually look like in each neighbourhood and for all the different work that we're doing. So it'd be really good to pick up that conversation as we start to develop this model and make sure that the independent sector do feel like they've got their voice heard and can help to shape it. Just looking at what other questions we had coming in. So there was one, I think there were a couple about investment into third sector. So there was one around core investment needed with neighbourhood networks, the third sector, because they're already involved in proactive care and supporting people. And there was another one asking specifically around the Birmingham model and whether they know that resource has been moved to third sector, and if not, whether there is an intention in Leeds. And then I think there was another one further down asking about whether in Leeds we're looking at that. I mean, the kind of first answer on this that wouldn't come as a surprise to anybody, I think, in this call, is that it is very difficult to move money around the system when everybody in the system feels that they are busy, they are under pressure, and they are being asked to make efficiency savings. So that there definitely isn't an easy solution to support all of the needs across everywhere. I think that there is a recognition of the really important role that neighbourhood networks and other third sector organisations play. Definitely my team absolutely champion the work that third sector organisations do, both connecting with their local care partnerships, but also one of the really great things about our jobs is that we do feel like we get to go out and see and experience firsthand all of the brilliant work that you do, and undoubtedly would say you have got such a vital role to play in neighbourhood health and in making this model work. And we also know just how stretched you are, the cuts that have had to be made in the sector, the really brilliant organisations that are announcing closures that are just so sad to see go. So it is really, really difficult. There's a lot of changes happening in the ICB, as people are probably aware, again, as part of that kind of national restructure. But the ICB in Leeds has been really supportive of developing a third sector strategy. So I've worked with third sector leaders and through Forum Central to really try and capture the value that third sector brings, but also to turn that into commissioning intention. So if you're a third sector person that's sat as part of the session today and you're not aware of that ICB third sector market strategy, I'm sure that Forum Central would happily share that with you. And on your behalf, they have brought the things like state of the sector into the ICB as well. So there's that definite recognition of both the value of the third sector and the challenging times that we've got. There just isn't those, like, you know, we can't sit here today and say, yeah, there's absolutely an intention to really invest in the third sector. I'm sure there would be a will to do that, but we can't say, yeah, as part of the neighbourhood model, this is what's happening. What we can do is keep collecting the evidence, the stories around the importance and the value that you play, and some of the things that Catherine described in a huge amount of detail today in terms of proactive care. It is that it's trying to really capture that whole picture of what are all of the things that are put in as inputs in terms of supporting people, and how do those things make a difference. So I know that's not a brilliant answer to give people. I think it's a really difficult question to be answering, and it's one that we find really difficult to answer to, because we absolutely do see and value you, but see the struggles that you've got there. Catherine, I don't know whether you want to try and pick off M's question, which is not a quick one to answer either, around IMD1. So Emma, could you please explain more about the health inequalities proposal to have 25% IMD1 as a measure for proactive care management if it's 25% of the whole population's in IMD1, but we know that people living in IMD1 are disproportionately experiencing multiple long-term conditions and have worse health outcomes. How is it equitable? Do you want to start on that one, and I can maybe chip in too?
That's absolutely fine. I'll have a go. I guess that 25% was that when you look at the kind of 47,000 people we've got in our kind of target population, 25% of people live in IMD1. So that's kind of just really a fact. It kind of reflects the fact that I think it's 26 or 27% of our population live in IMD1, but I think is probably, when you look at it on a kind of age-adjusted basis, is probably a little bit higher than we might expect due to kind of life expectancy, etc., in those areas. What we're doing is as Kim set out, is we're working with each LCP and PCN to say, which of those three populations are you looking to target? So the kind of three populations around the multiple long-term conditions, moderate severe frailty, or both. And then when we then look at that population, so for example, I was working with an LCP the other day, and it was the population they chose had got 1,200 people in it. We're not going to proactively manage 1,200 people. We've got to get it down to about 30 through working with people and through looking at that population, through understanding the inequality in there. So the reality is that actually when we do that sort of work, many of the LCPs are working on, say, okay, which populations have the highest rate of utilisation, for example, and we know that in the city, people living in IMD1 have a much higher unplanned care utilisation than people in kind of IMD10. It really is that kind of inverse care law. And then through looking at that population, what we find is generally there's a higher number of people from IMD1 than there are from the other deciles. So we haven't set a target for IMD1, but what we're looking at, what we're working with each PCN to look at, is who are the people who are most impacted, who we can have the most impact on. And I think through doing that, one of the lens we're looking at through is inequality. So I think that what we'll need to do is, as we look to evaluate the programme, is to understand the proportion of people on there who are being proactively managed from IMD1, but I imagine that's likely to be, with the sorts of lenses we're putting on this, higher than the 25%, because we just know, like we saw in the slide with the disproportionate impact, that's way higher when you look at IMD1. So if you kind of want to add to that, Kim.
I think just to say that in terms of the approach that we're taking in Leeds, it is to really try and look through that lens of deprivation and make sure that we are doing some really targeted work there. But in terms of the neighbourhood model, we need to make sure that the neighbourhood model works for all populations and all communities. And part of what we're doing with proactive care is asking each local care partnership to do some focused work with their population. So they are looking at who are the people who would most benefit from proactive care and are most in need within their population. But obviously our local care partnerships are very diverse and different. So for some local care partnerships, they either have very little or no population that live in IMD decile 1. It might be different populations that they would look at. We're taking a completely different approach with Leeds Student Medical and the like, because they've got a very different population and they're not a typical geographical neighbourhood, but we are looking to do some proactive care everywhere. We're very much seeing this as a learning year from that, and it may be that we have a more kind of targeted and proactive approach that looks a little different going forward next year onwards. Just trying to spot some of the questions I've missed. I've realised that we're on time, everybody. I'm happy to answer some more questions, but I appreciate people may need to disappear off the call. There was one around how the model, and I think it popped up around the time we were talking about neighbourhood health and the 10-year plan. How does this address social isolation, which can impact on many, both with serious conditions or mental health? So I would absolutely agree that I think social isolation is a real challenge, and can, I think just social isolation itself, whether it is for a person who's got ill health or whether it's for their carer, can negatively impact on both their physical and mental health. So you can end up in that kind of vicious cycle of you get socially isolated because of that, but then your conditions worsen because you're socially isolated. I think that some of the things that we are developing and designing, it's got opportunities for social connection built into that. So for example, we're doing a piece of work in York Road around falls, where we're just about to launch a falls prevention hub, and we've really thought there about what the barriers are to people who might be housebound or might have fallen, lacked confidence in engaging and connecting into things. So when people are coming in that area to strengthen balance, we will be trialling a transport offer that makes it easier for people to get in, and we will also be providing a food and refreshment offer that brings much more of a social aspect to it, so that we can hope that people can actually feel like they're not just coming for what could be seen as a kind of health appointment, but they're also able to connect with other people that they might have things in common with that are from their own area. And from that, they might be supported into other activities that are also going on in the same centre. So that's just kind of one small example of how we're looking to try and build social connection into some of this stuff. There's a real focus on some of the younger groups that have got long-term conditions and multiple long-term conditions. And one of the things that we're looking at there is what we can learn from some of the peer support work that has been done in a number of different places, so that again people can actually support one another, that it isn't all fully reliant on health services, but that actually people have also got those opportunities to learn together, to support each other, to feel like actually I'm not the only person going through this. So how do we learn from some of those things that are really positive ways of people being connected together and able to support each other? There was one about the survey, or a couple of comments about the survey that Catherine mentioned. So we sent out a baseline survey. We sent it out to everybody on the Local Care Partnership mailing list, which is quite considerable. We had it in the Local Care Partnership Digest for a number of weeks to promote. We had it at events, and we asked partners to circulate it. The health and care workforce is a huge workforce, so inevitably it will have landed with somebody in your organisation, but it won't necessarily have gone to you. That survey, the analysis has been done of it now. There's a draft circulating around that I'm hoping to get my hands on next week, and that will be used as a starting point for our development plans locally. But it is a survey that we'll be looking to repeat, so we will be looking to do it again in about 6 months' time, and then as an annual spot check of how this proactive care work is going. But we won't just be using that survey. So if you connect with your local care partnership, there will be other opportunities there to actually have conversations with you and look at how we develop this work further. So what are the things that make a difference to you in terms of how you work with other partners locally? So if you did miss out on that opportunity to complete the survey this time, there will be other opportunities for you to connect and share how you would like to be involved in this piece of work. So it's not, sorry, you've missed it. It's actually, let's look at the other ways that we can do that. The other thing is that as part of this work, we are very happy to come out to, for third sector, any of the forums that you have that bring a number of third sector partners together. We're happy to come out and have conversations around how this works with your sector. for the bigger organisations, for primary care, we're happy to come out to any of your kind of team meetings, or again, any of those groups where it maybe brings a subset of managers together or a subset of leaders that can then bring things to their teams, or come to specific staff teams to talk about some of this. So just think about if there are particular things that you would help in terms of engagement and that kind of broader Home First Phase 2 programme. We have made that offer out to leaders as well to say what are the things that will help you get some of this out into your teams and talking and flagging up how we can make this happen together. Just seeing what else. So there's a couple of comments around care being cut back or potentially cut back. So some things that are kind of national decisions in terms of what is or isn't available through the NHS and funded. And then there was one around how do we ensure individuals are not being sent home early to free up beds. So in terms of what good quality care looks like, nobody should be getting discharged from a hospital bed unless they are medically fit to be discharged. I think that is different to people feeling like they've got the confidence to go home, that they've got the support that they need wrapped around them when they go home, or that as somebody's relative, friend or carer that you feel like you've actually got that support. And I think that one of the things that we would want to see with proactive care is that people have got a care plan that works for them, that if they've got a carer, the carer has had that opportunity to have a conversation and feel supported and share their needs, and that it feels like something that we're in partnership on and that we are doing together. And that's one of the really key things in terms of some of the advanced respiratory work. So that case study that was shared of the couple where he had advanced respiratory condition, it's about having that care coordinator that is working with the family, that is understanding what that family's whole needs are and how best to support them, so that hopefully we can reduce down the amount of times that people need to go into hospital because they're properly supported in their own home, but also that if they've had a period in hospital, that plan to get them home and for them to feel properly supported when they are home is also built together. So I think that's probably the best I can say in relation to answering that question. And I'm sure there's always people that have got poor experiences to tell, which is again part of why we're really trying to think about, in terms of evaluation, how do we build that up and do something that reflects all of the different perspectives, so staff, people, carers, whether this is actually working for them. Right, I can't spot many more questions. There's a comment from Councillor Shazad saying lots of residents are not aware of what the local care partnerships offer in different areas, and communication amongst the different departments and doctors' surgeries is disjointed. I think there are almost two separate points there. In terms of the local care partnerships, some of our local care partnerships do quite a lot of public facing events in their communities, and for some of them they will use local care partnerships as their branding, or it will go alongside the branding of partners. For other areas where they maybe don't do that, I really don't care if local people have no idea what a local care partnership is, if actually what they experience is really great joined up care from the people that they go to. So they maybe need to know how to get into their doctors, that they feel like they can get to the doctor when they need to, and that they then have a really joined up experience, whether it is a third sector partner or another bit of the health service that is then supporting them. I think it is that disjointed care bit that is the problem, that we need to get right. And this is where we were describing how we're starting with those people who make most use of health services, because the fact that they're using services more, they're much more likely to experience that disjointed care. And then that other bit around just navigating and knowing what is out there. Some of that is maybe about how we develop that digital offer and how we really think about our digital inclusion strategy so that more people know how to find things. But also we then have the things like social prescribers and a kind of wealth of services out there that support and help people to navigate the kind of broader support that's available. So that's maybe the other bit that we need to think about. And that is one of the things that I think is a real opportunity with this neighbourhood hub option, that if we talked about potentially the smaller hubs, so thinking about community centres run by third sectors, the council hubs, if people felt like that was the kind of starting point, that they knew that that was within walking distance of their home, that they could get access to a range of things with that as the portal, I think that is a potential opportunity for us to really feel like that front end and helping people navigate is joined up a lot more. Right, okay, everybody, I feel that we've certainly exhausted half of you because we've had a number of people drop off the call. I feel like hopefully we have got through everything. Sorry, Councillor Shazad, I can see you've come back to that. Will the local care partnerships work with the council community committees who are felt wellbeing champions? Absolutely, yes. So each of the community committees have just re-elected people to link into their local care partnerships. So you should all have a named councillor that links to the local care partnerships. We are always happy to meet with you, especially if you can't make when your local care partnership meetings happen. One of my team's always happy to connect with you. But also we have been into some of the community committees under the old structure to bring in reports, have a conversation about things, and we're always happy to do that as well. So if you want to just kind of message me, get in touch with one of us, we can have a chat around what's right for your community committee around that, but definitely keen to look at how we make sure that we are joined up with yourselves on this one. Brilliant to have so much interest from everybody today and so many brilliant questions, and we thought we'd put in 90 minutes because that should be plenty of time for us to go through a lot of information but also answer all of your questions. But clearly this is something that we could just keep talking about. So we're happy to do another one of these sessions in a few months' time around the kind of where are we now, but do keep pushing questions our way and we can feed them into. There'll be lots of opportunities for people to get involved in neighbourhood health, but if you've got particular questions, particular thoughts, just push them in and we'll just make sure that we do continue to shape it up. I am going to draw a close to today. Thank you so much, Catherine and Rachel, for co-presenting with me, and for the rest of my team behind the scenes who have been messaging and keeping an eye on a chat and letting people in and all of that stuff. We will get the recording and the slides out to everybody afterwards. Do feel free to share those with colleagues that weren't able to come today. That's also absolutely fine. Fab to see you all and catch you later. Bye, everybody.
Thank you. Bye.